RetinAI Discovery is our image management system, and as Carlos mentioned, this is actually MDR CE marked in the European Union, and it's our multimodality image platform. So OCTs from different devices, fundus photography, we're centralizing all of those images onto a unified platform. And as you can see, we have AI built into the system. So we have more than 10 algorithms, 3 of which have been CE marked for the European Union. And what this allows for, having the platform, is seeing the AI segmentation, actually being able to visualize the layers, the biomarkers, and being able to measure this over time. We have compliance with GDPR, so we have all the patient security, data privacy regulations. We follow that to a T. We also offer HIPAA compliance in the US market, but more importantly in the European Union, we are GDPR compliant. We have smart workflow functions, so in terms of the specialists who are connected to their referrals, you can connect seamlessly through the platform to have those patient referrals even much faster. The clinical, if your center is involved in clinical research, there are workflows related to expediting how you operate your clinical studies, how you enroll those patients, and certainly the real-time assessment between your peers. And lastly, what the platform allows for is the ability to take data within your clinic, especially that imaging data that needs to be unlocked and provide value. So taking that clinical data and generating this real-world evidence. So those biomarker measures, looking at those trends over time, and that's really key to potential stakeholders for the clinic, especially if you have pharma sponsors who are interested in your sites in terms of recruiting for clinical studies. So as mentioned, we have 3 AI algorithms that have been approved in the European Union. So that's for layer segmentation, fluid segmentation, as well as identifying biomarkers and giving a presence-absence of those biomarkers. The image management system, again, that's RetinAI Discovery, has also been cleared for clinical use in the European market. We also have research use only AI models that are built into the platform and can be used to do some retrospective analysis on data that's in your clinic. And coming hopefully very soon is the diabetic retinopathy screening algorithm, which hopefully I think by the end of the year we're very excited to get approval for. We're waiting on that. Just a little bit about our segmentations. So the model here that I'm showing you is actually a research use only model. We call it the advanced segmentation, and it's looking at 13 morphological structures on the OCT. So we're looking at layers, we're looking at fluid, we're looking at biomarkers. So just to run you through, we segment the choroid, then the outer retinal layers of the RPE, the photoreceptor layer, the myoid zone, the ONL to HFL, and then the inner retinal layers, the INL to OPL, the GCL to IPL, and then the retinal nerve fiber layer. We also segment pigment epithelial detachment, or drusen. We also segment this amorphous material, or subretinal hyperreflective material, intraretinal fluid, or CIS, subretinal fluid, and hyperreflective foci. One of the models that is very interesting for us, it's a research use only model, but it's for geographic atrophy. And through our segmentations on OCT, so looking at the entire OCT volume by B-scan, we can actually project this en-face representation of atrophy. And then we can also see how that lesion will grow into the future, and that's the dotted white line around. So very powerful tool when you think of educating patients and hopefully one day, compliance to treatments that are introduced into the market here. And then this is just another representation of how we, based on our segmentations, we can actually calculate the area of loss in the outer retinal layers. Those are those 4 segments on the top there. And then on the bottom, you'll see a plotted graph, and the part in green are all the visits to date for a particular patient, for your patient. And on that last visit, what the algorithm does is it projects out how that atrophy will grow, looking at the different frames around the fovea. We also have progression analytics, so very powerful, especially in neovascular AMD, when you're looking at volumes of subretinal fluid, intraretinal fluid, PED, and how that patient is doing over time, especially at the point that treatment is administered, what happens on that next visit. So we can also do this progression analytics for layer thickness, and of course look at the change over time. We have a comparison view. So when your patient comes in and you're looking at the previous visit and you're comparing to the current visit, they have a visual of what's actually going on, and you can see the progression analytics below, so they have a sense and a concept of what's going on with their disease and certainly treatment. Lastly, we're very excited to be working on this. This will be introduced early part of next year. But one of our goals is removing any of the manual steps associated with uploading data, getting data into our RetinAI Discovery Platform. So we're working on a tool right now and actually testing it in several clinics where we are automatically pushing data into RetinAI Discovery. And this can be configured to your clinical needs. So whether or not that data needs to be anonymized right away as it goes to the platform, any new acquisition that's added to your imaging repository will automatically be pushed to RetinAI Discovery. So there's no manual steps, no additional IT requirements, and lastly, as I mentioned, the anonymization and customized configurations, this could be done to your clinical needs. So very powerful in terms of especially looking at the clinic as a whole, any of the business analytics that you want to do, any of the disease analytics that you want to do, to be able to actually have access to that imaging data. So, with great pleasure, I'd like to introduce Dr. Audre Ambresin. She is a medical director and associate co-founder, right, of the clinic in Lausanne. She's also a medical retina specialist at Swiss Physio in Lausanne, one of the largest ophthalmology networks. And she leads the clinical trial unit at the clinic there with an interest in AMD and an interest in integrating AI into clinical research. So, my pleasure, and let me just pull up your slides.
Good morning, everybody. So thank you for the very nice introduction, and I really hope I was asked to share with you my real-life experience with AI in clinic and in research, and I'm really hoping that the message this morning is going to help you in few matters that we all have to face as clinicians, especially in medical retina, looking at the future of our job that is obviously moving towards a new era. So integrating discovery in real-life setting, and that is, as just said, addressing age-related macular degeneration this morning. So these are the financial disclosure, but none are related to this presentation. So ophthalmology, as we know, is one of the busiest subspecialty in terms of clinical appointments, and the healthcare system worldwide are challenged to provide adequate care for the 200 million individuals with AMD. And we have evidence that approximately 25% of the population aged more than 60 are estimated to have early and intermediate AMD, and this number, as we know, is rapidly growing due to older age population. So what does that mean? It's meaning that we have to address a high volume pathology. And worldwide, approximately 8-9% of the population is affected at various stages, of course. And that means, and I wanted to show that in a small country like Switzerland, it's still a very high number that we have to deal with. And that is really increasing in terms of any kind of AMD starting from 70 years onwards. So we've chosen to look at a few use cases in AMD and divided that in the patient journey. How can AI actually change maybe your patient journey in your clinic, diagnostic and treatment of AMD, and in research, clinical research. So the first use case that we're going to use in AMD is neovascular AMD, because that's the one that we're all dealing, and that's actually where we're going to spend much of the time this morning, because that's what we're dealing with in the everyday practice. So neovascular AMD, nothing overused, most severe form of AMD in terms that it leads to rapid vision loss if not treated promptly and regularly, meaning, as you know, regular appointment, frequent visit, repeated injection, and that is a very high burden on both patient, relatives, and practice, doctors and clinics. But also, because of the high volume and the epidemiology of the AMD, research in academic setting is highly required. As you know, the management, molecules, and imaging of AMD is rapidly evolving. And looking at all these images is a very high volume of data, and that will be probably need to have the support of AI. So basically, in neovascular AMD, AI integration has the potential, that is of course personal thought, but I need to improve the patient experience, optimize AMD management, and assist in research. And we're going to go through these different boxes. So let's go for the first use case, which is facilitating the patient journey. So basically, these are the current challenges that we have. So neovascular AMD clinic has dual challenges. So first, it has to address the healthcare provider needs, but also the patient needs. And in terms of healthcare provider, as we said before, high volume clinic, time constraints, we have to look at all these images, and we have to take therapeutic decisions that do matter. I mean, sometimes we're just in a busy clinic, but that really do matter for the patient. And for the patient, it means coming and back and forth for this visit, waiting time at the clinic, and of course anxiety also. When they're not having such a defined and personalized in advance, that really leads towards anxiety. And I was surprised looking at this study that actually we do know that 30% of our patients with AMD are depressed and anxious towards the chronic disease that is AMD. So we really need to improve this patient journey, if I may say, with AMD. So what would AI integration, to my thoughts, really change looking towards healthcare provider? So overloaded clinic, the AI may help to improve the flow, gaining time, as we would be assisted for image interpretation. Also, because we would move towards more personalized treatment with predictive analysis, this can also actually help the time that we're going to spend with the patient with more personalized treatment. Accurate image monitoring, sometimes it would assist us, sometimes in busy clinic, it's hard to look at all the scans, and this would actually do the job for us. And patient education and assistance, we have to repeat and explain to the patient many times the same things. I think we all face that. And having AI chatbots, for example, helping us with education may also actually save time and be very efficient for patients. So regarding now the AI integration facilitating the journey for the patient. So the patient, as said, needs to come back and forth, and as you know, most of the time needs to have someone with them.
And to have a disease progression predictive model that may reduce the number of time that the patient needs to travel to the clinic. Also, if we would have AI-assisted home or self-monitoring, that would also help to not come for the clinic if there is nothing there happening. Expectation also towards the functional outcome, and I think that is really the main point. If our patient, what do they expect is they have expectation towards vision. And really, I think that with higher disease control, we do know that we do improve the functional outcome. And again, coming back to this uncertainty about treatment schedule, if we can tailor and plan in advance, I think that really, and that has been shown that does really lower the anxiety of the patient towards treatment. So how did I plan to integrate AI in my daily practice? And I really hope that is going to mirror a bit all practice that you do have. I do not have a specialized clinic for that really different from yours. This is in the database of the research center that I'm dealing with. The database does have, that is not representing the whole patient, all the patients, but the patient that do have all the data in the database, all the metadata to go for research. So what I wanted to show here is that I do have AMD prevalence, and I think we all do have. And why do I say that? Because I think that having AMD prevalence really makes an ideal clinic for integrating AI, because that is high volume and that is a lot of images that we have to look at. So here we go to the first. I have two aims that I'm going to share with you this morning, and that is the first. Aims of AI integration, improving the patient journey. And now we're not into the theory as before as how AI could make it, but how I think in my practice, in my real life, it could actually happen. So the patient volume, that's the current situation now. The patient volume related to the staff is such that the medical staff is under great pressure, and I think we all live that. This translates to long waiting time for the patient and, as said, increase the therapeutic burden. So this current overload of clinic that we all face may bring three main damaging points. So patient dissatisfaction, increased therapeutic burden, triggering distress, and loss of follow-up. We will get back to that. And lack of logistic efficiency and suboptimal patient flow. So the weak point of the current patient journey that I have in my clinic is that. So basically, what is the flow? Patient arrives, wait until seeing the optometrist or the technician. And then as they're going towards vision, OCT, and other testing and imaging testing, they finish with that, they wait. And then they wait for the doctor, so that's probably the worst part. And then, again, they've seen the doctors, they discuss with the doctors, and it's a one-step clinic, so they go for the injection, but they wait. So these waiting times, there is one soft spot, I think, that I can really help with AI, which is the second waiting time. So weak point are neovascular patients so far are mixed with other diseases, sometimes difficult diseases that we have to deal with in retina. It is all disconnected between the steps, and this accumulation of waiting time make the patient unhappy and make treatment discontinuation. And I really want to stress on that, because we all think that our patient comes back and we are doing such a great job in clinic, and we know from a general study that over 30 to 50% of the patient actually drop out of the clinic after 2 years with neovascular AMD with such a potent treatment. And I wanted to look in my casuistic, because Swiss people are really, strict, and they come to the clinic and we thought they would be so good. But actually, even here, we do have a dropout that is quite important. So we may have the best molecules ever, still patients are dropping out. So we need to improve the patient journey if we want to achieve better visual outcome. So really, I think the image, where we can really integrate is the helping the ophthalmologist with images interpretation and treatment decision, because that will really decrease the time that we're looking at images, turning our back from the patient, looking at images, and not talking to the patient. So we can actually convert that into quality time with the patient because we will be helped with AI imaging. So, of course, I think this looking at images, we will all agree that it's not so difficult. Do we need AI to think that there is fluid in this compartment? Definitely, that's not so convincing, what I'm presenting this morning. So I think you will say, no, I mean, for that I don't need AI. And I agree, you don't need AI. Only the fact that we can have in this segmentation, this 5-layer segmentation that is today released for clinical, looking at this compartment of fluid, you can see how we actually can measure the fluid. So it doesn't matter that much. It's active. We need to treat. We know that. But still, it can measure volumes. And it does matter because when you look at a case like this, the upper row, again, nobody I think here, being specialist of retina, would actually need that much to look at this AI tool. But still, we can actually, I think one thing that is very important, you can see in this treatment patient that was treated with, in the case here with faricimab, how quickly the intraretinal fluid does actually go away. And we do know that the early responses in treatment, mostly regarding intraretinal fluid, is actually predictive factors for increasing the interval, for having better visual outcomes. So it can also help actually in the discussion with the patient, oh, you dried out your retina so quickly, that may actually be a good prognostic factor. But down there, maybe, early morning, I'm really happy looking at my OCT, I mean, yeah, you kind of all look the same. But here, you can actually see that when you look at the PED value, you can see that over time, from months 4 to months 12, which you can see that the PED volume keep on decreasing. And that, I can assure you, that will make a difference in terms of looking at small volumes, because that we don't have the time. No way that we can have the time, and we can have this human eye being able to look at all these little changes. Of course, I would agree, maybe some of you say, and what does that change for my patient if the PED is 10 nanoliters less volume? It's not that matters so much at the end of the day in that specific case. But what I wanted to stress there is the importance of looking at small volumes and how, as a clinician, it's hard to pick up in each scan this difference of volume. So another example, and that's the last one I'm going to share with you, that's a patient that was loaded with aflibercept 8 milligram. And again, you can see how through the loading dose, it actually dried out up to having a fibrotic PED with absence of fluid. And my treatment scheme for Eylea 8 milligram is then for naive patients to actually stop treating and monitor them monthly until they may have a recurrence with a capped regimen treatment up to 16 weeks where there is a mandatory IVI. So that's what we did. And we actually looked for the first months, and we can see that the volumes were exactly the same. But at month 3, after the end of the loading, we could, by AI, measure that the PED, and I'm sorry it's not showing the volumes, is actually increasing again with a little bit of intraretinal fluid. And that made us think that is the time to retreat. So actually, I think this does help. Again, busy clinic, small volumes, looking at all the scans, I think that is really helping us in facilitating imaging analysis in clinic. So how do I now plan about integrating that, helping patient journey and image analysis? So really, what I think now is the following, compared to the weak point that we've shared before for the current management of the patient. So the patient would arrive, would be examined by optometrists that would, in the same room, and that would come later, do the corrected vision and the OCT examination. And this will be then even better when we will have to connect performance of the RetinAI system will be exported to the Discovery Platform by the optometrist, and already a bit of a decision could be taken. Of course, it should be looked at by a doctor and the modern junior doctors, and I will be always looking as a retina specialist. We have legal issue behind that, but I will review the images. But still, the patient would go down this line much quicker by saving some of the waiting time that we've seen in the current way of dealing with patient journey in a busy AMD clinic. So basically, again, looking at the discovery platform, helping in the image analysis, doing the examination, best corrected vision and OCT in the same room, with AI image reading, we get again in waiting time. And we made a bit of a calculation here to always, that is our practice, that basically it will reduce the waiting time by 50 to 80%. So that calculates if the patient are just living too good and 30 minutes they're gone, you know, then maybe what I'm saying here is not so useful. But if you are more towards the 3 hours or 2 hours for just having one OCT and one injection, maybe that will also make you think that we can actually reduce that time, so actually decreasing, and at the end of the day, decreasing the risk for discontinuation of treatment for our patients. So not only, and you know, I'm just touching a little bit of okay, how do I convince the admin to actually follow me on that? Because of course, that's also an issue. So I think by time saving, there is a direct improvement in the quality of patient of care. Maybe they would not be too sensitive to that, but still, I think they like that patients are well treated. They like that. Spending less time, which will increase patient satisfaction and attenuation of patient burden. And I think at the end of the day, saying that the patient would be satisfied, the clinic reputation will get higher, they will be happy with us, and also, of course, if you can see the patient quicker, you can increase the number of patients while you can actually stay with obviously the same staff. So I think that, and we know staff is a real issue in terms of money-wise for the clinic, at least in Switzerland, it is really high. So, you know, kind of a business plan here that I'm sharing with you that maybe may help you to actually discuss with the administrative authority of your clinic and hospital. So, really I spent a lot of time on neovascular AMD because that's what we're dealing with so far in our basic clinic. But just a small hint on geographic atrophy. The patient journey, I have a dedicated GA clinic because, again, therapeutics should come, and this is really a specific disease. We should not mix GA with wet AMD. They have different expectations. Again, I have a full slide deck about that, but they even are more stressed, they need more explanation. So it's a different set of patients that should not be mixed, and that is my thought again with a wet AMD patient. And so the journey is very different. And I think what is quite impressive is the number of testing that should be performed. You know, we have to go for low luminance vision, we have to go for micropyrometry, we have to go for blue light autofluorescence, because that is what has been approved in terms of the FDA of the outcome in terms of anatomy for GA therapeutics. So looking at the blue light autofluorescence, both done by the optometrist and then having to be looked at by us using the so far manual or semi-automated methods like region finder that you do have on your Heidelberg if you're using Heidelberg, can help you so far to look at the progression rate. And basically the fellows that do work with me in the GA clinic, they are so keen on having another tool than Region Finder to measure the area that I ask them to measure for each visit. So again, GA, that's basically what we're doing now. Maybe you're doing it manually, like grading the outline of the GA lesion with the cursor. That is simple because it's a standard software, but it is really time consuming. And even us, as using the semi-automated method of the region finder, it's actually improving a bit, but still, this is more efficient than manual, but still, it is complex, and maybe some of you have tried that. It actually superimposed the fovea because it's a matter of reflectivity of the background, so it's hard to distinguish the fovea. So it's not that easy and convincing to actually measure the area in millimeter square of the GA. So this is an example here of what we're doing in my clinic, an example of a patient that has a unifocal extrafoveal lesion on the blue light autofluorescence that is slightly outside the fovea. The baseline atrophic size, and you know it matters regarding the progression rate and the prediction for progression in GA, that has been measured over December 2024 to 22 to 24, and it's increasing by the region finder. In the area has been shown here on the slide, but you can also see that there is a small video here, so you can see that it is increasing. So maybe you would say, okay, no need for that, but that is actually giving you measures, and we have to refer to metrics to actually really go towards prediction and also considering patient towards when it will be the time for us in Europe, treatment or non-treatment. So advanced GA lesion measurement with AI, I'm really confident that it will really help us in clinic when it will be usable in clinic, because it has been said before, it's so far a research tool only, but still it can help us, and I'm just going to briefly say that it will hopefully increase accuracy and lessen the time consumption that we spend in the GA clinic. So now I'm moving towards research. So we spoke about how the patient journey could be helped. We spoke about how, because of the image analysis system that will reduce the time and be more accurate, both in neovascular AMD and GA, it can actually help and facilitate both the everyday life of the patient and the doctors. Now we're moving towards how AI could, in research, if you perform clinical research, how it can also actually help us. So in clinical research with AMD, we need to deal with baseline variables such as demographic, disease risk factors, functional measures, and we know that is a load of variables that we have for our patients at baseline and throughout the treatment. We also have to look at OCT biomarkers, and by analyzing these biomarkers more carefully, we may actually also help the patient stratification, and so having more results in research looking at these specific biomarkers. So variables are very important, OCT biomarkers are very important, but also enhancing to look at pattern, maybe pattern that we would not recognize, and actually AI would recognize and tell us, look, why is that all these patients that are, I don't know, at 10-minute interval are actually having this pattern. They would have the possibility to help us putting all these together. And as we said, predictive model. I think really prediction, both in neovascular AMD as it was shown, not only comparing. We usually say in our patient, look, it was like this and now it's like that. So we're actually dealing with comparison. But really this progression is really also important. And I think that will also be in research. So in clinical research, we all know a lot of new molecules came out, and some other are to come, both in neovascular AMD and GA. So it's really needed that we can test safety and efficacy in real world. And actually answer to this question, which molecule is the best for specific OCT biomarkers, what OCT biomarkers at baseline and over the treatment curves are predicted for better outcome. All these questions that we're actually facing in our real life everyday clinic needs to be answered first by research. And of course, this is just two examples, but many more are in your head and in your brain. and that needs to be addressed. I just took the example for prediction in research. For example, regarding the treatment frequency, I think already a lot of papers are out how actually AI could help to predict, for example, the need for retreatment. And this is precious because we need to speak with our patient. We need to tell them, you know, in which category you may end up. Are you going to have treatment forever? Or are you going to be a very early responder and maybe you can stop treatment? These, of course, this is as an overall, but this is really helping us towards treatment expectation that our patient have. So really, I think the clinical relevance here is really that AI can potentially evaluate the expected treatment burden for individual patients. So how did I actually set that up in my clinical research setting? So that's the standard. We look at best corrected vision when we decide to go for a clinical study. We look at best corrected vision, we look at CRT, we look at thickness map, we look at the PD height, and we look at IRF, subretinal fluid, sub-RPE fluid, yes, no. That's basically what we do. And we all say how unhappy we are with the pivotal study that actually does show CRT. Are you looking at CRT when you treat your patient? You're looking at all the scans because you want to see the fluid in all the volume compartments. So that is what we have also in research. So that's what you can do. So that's, you know, looking at, for example, here, naive patient with treated with faricimab, looking at how the visual outcome could be after 12 months and how actually also the CRT and the PED would decrease. Okay, that is good, it's functioning, but it's not exactly mirroring what we're looking into in clinic. So when we can, and that is the second part of why should I integrate AI is in research. So again, same patient, and how we can actually assist that with looking at AI. First, we could superimpose what your software with RetinAI would help to actually measure the volume that we've seen before, and having really metrics of the volumes. So really it's in the detailed quantification of the retinal fluid volumes and dynamic. And really that helps and that matters because, for example, in this faricimab, a naive cohort that I did study with AI, I was actually able to show that after 12 months of faricimab, all the metrics were significantly reduced at month 12. And looking at that in the graphic, you can see, for example, how quickly it responds after 1 month for all the fluid, but how actually, for example, PED needs time to actually kick in. And I think really, if we would not have the volume metrics, it would be really hard to actually demonstrate something like that. So that is really helped by using AI in research. And now looking at the biomarkers, again, if you have fellows, they would be very happy because if you ask them to count the hyperreflective foci for a cohort of 100 patients, looking at 97 B scans for each of the patients during 12 months, I don't know how many hyperreflective foci they will have counting, but I mean, that is impossible. So again, looking now at these biomarkers like hyperreflective foci, we've understood that it is still the advanced segmentation, so it's yet for clinical purposes, but that really is meaningful. And I don't know whether some of you have, for example, heard of the communication how in faricimab, for example, hyperreflective foci do decrease significantly during the treatment for naive and pre-treated TME patients. So this is a really important biomarkers. And again, an example here of this patient where we superimposed the OCT metrics of the hyperreflective foci, and you can see how the system is actually able to count the foci for you over not only one B scan, but through the whole image. And that does matter, as I said. We have now example regarding treatment outcomes, but also regarding disease progression that has already been published, and that helps to distinguish low-risk and high-risk patients and actually assess the impact of treatment on disease progression. And finally now for GA cohort, what could we do? Again, this is for research purposes, but using the AI algorithm. I think it was touched on before by Sandra, so thank you so much for that. But just like repeating that we do have in RetinAI a figurative example here of a patient that was followed over 6 years, and you can obviously already see that it's actually increasing. But the green segmentation that is put here as a mask on top of your images, and that is taken again on B-scan of the whole image, you can see how, for example, the fovea is spared on the top line, but how it progressively would disappear. And here, we really believe that it can really reflect reality compared to what we just discussed before, for example, with Region Finder, where you have this confounding of the blue light cutoff fluorescent that is well absorbed by the pigment. So this is like the area. But also, as it was said, the lesion progression tool that is now being shown here. And also here you can see the projection of the area in millimeters square that was not shown before, and how it's actually increasing, and how the loss is predicted by this dotted white line over time. And again, that can really, I think, help us in the future, hopefully, in clinic, to help concealing our patient towards the therapeutic that hopefully we will get. So I think really in conclusion, the AI implementation model in an AMD-dedicated clinic, that is the present and the future, some is already happening and some are in the future. Improving the patient journey, I hope you were convinced that it can help. Satisfaction by reducing the time by AI-assisted image analysis, and reducing the burden on the staff and high-volume clinics, such as in an AMD clinic. And I think it also can influence positively the clinic reputation and increase the patient volume without, in parallel, increasing the burden on the staff. And also, second point of implementation is research, and I think it will really enhance and support clinical research in neovascular AMD and GA by allowing quicker look into fluid dynamics and volume, image biomarkers, and helping looking into predictive models. And with that, I hope that was helpful for you, and I'm very pleased, and thank you for being here this morning, and thank you for your attention.
Thank you, Dr. Ambresin. Very excellent presentation. And I think at this point we want to open it up for any questions that people have. A very simple question from me, but what do your patients, what are your patients' impression when they see the AI overlay on their images, and sort of what they, I guess the feeling that they're left with?
I think that this is really depending on the amount of fluid. I think this is an important distinction, because I think the patient, and I think we all can testimony that they almost, for neovascular AMD, as educated as they are when they're frequent flyers, they can look at OCT and say, oh, there's fluid already coming back. I mean, I'm sure you can all testimony that, especially with high volumes. But sometimes when you have, over time, to convince them to come back and back and back for treatment, and you actually hardly can see, we can see, because we have the eye to analyze the images, but they would not see the difference. They're not so well, they do not see so well, they're not educated, and you can actually, by AI, say, look, I mean, it looks kind of the same, but look at the fluid, it's actually increasing. They actually, to me, this helps them to be more adherent to treatment, because they can actually see somehow that yes, it is required either to shorten the interval or maybe sometimes hopefully to increase the interval, but most of that is to come back to the clinic, because again, I know what the molecules are doing. We're so happy with the molecule, but we lose the patient. And whatever the molecule can be, if we lose 30 to 50% of our patient after 2 years of treatment, and that is exactly what is there in the literature, we need to improve the adherence. And I'm convinced with these very small volumes that this is of a help.
Well, thank you very much for your so interesting presentation. I'm Luisa Frizzero from Italy, Padua, and I just have some curiosity because what will be the time? If I understood, there will be an upload of the data and a download of the analyzed data. So how much does it take in time? And if there are some quality standard of the image. There are patients who are not fixating or have cataract, so does it work anyway? And there is a standard of precision, and also sometimes we need to refocus the fovea, or maybe the layering still in our OCT device is not perfect. So there is a way to modify the image. It's the system that modify, or there is an operator. How does it work?
I think that will be a two hands answer. So first of all, this system can be implemented in different systems, and we're using the Heidelberg. So whatever you need as a quality image to judge for your patient in clinic with Heidelberg will be somehow sufficient to be in the Discovery platform. But now regarding the time that is needed, it's quite high now because we need to drag the image into the system. But that is what is going to be so well improved by the Connect. And now for the technical issue, I'll leave it to you.
Good. So for the time that it takes to go into the platform, it really depends on the device that you're using. We are targeting something lower than 5 minutes. Today, when you go with a size device, we will be between 1 and 2 minutes. So that means that from the moment that you take, and it really depends on the configuration of your clinic, but from the moment that you take the image, that data is going to be put in the database. Then there's going to be a system that is synchronizing that data and pushing it automatically to the cloud. It depends on the speed and connection. Also, if you want to add anonymization, this may add a couple of seconds, but then in less than 2 minutes you should have the results of the AI algorithm for the patient that you have, at least for a size device.
And that's for volume scan, for a single volume scan.
Yes.
And if we have follow-up, like you showed, the time is multiplied.
No, because the follow-ups would already be in the platform. You are just uploading the new image. That means that you already have the results of the AI algorithm that you have in the platform, and you are only loading the new image and getting the results of the new image.
Okay.
So that doesn't need to be done again.
Okay, so they remain in the server. They remain in the cloud.
Yes.
Anonymized.
You may choose. The platform is GDPR compliant. That means that, and we have absolutely no access because it's in the cloud. We have absolutely no access. It's like a blue box. It's like this is your own institution. Nobody else has access. It's GDPR compliant and MDR approved. So it's within Amazon Web Services. So you have all the security of a very large software company. And so that security and that level of security will already be there.
Okay. And what about the possible modification of the fovea if there is severe edema, or sometimes it's not perfect? So the image will be not modified.
It would really depend if you are taking another scan, because then it will be uploaded again in the platform. The good thing, and we haven't seen a screenshot of Discovery, but you will have like multiple images. So if you take a new one, then they will have this new version of the image uploaded and processed as well.
So the system will be modified the fovea according to all the images uploaded?
So we should go to the specific cases, but in principle, yes.
Okay. And another thing, in Heidelberg, you know that's fantastic, so you take the volume and you put it in the system. But there are other devices which have not the possibility to download the volume, and you have to take each image of the volume.
It really depends on the specifics of the device. So I cannot give you all the details because today we are supporting fully Topcon devices, Heidelberg devices, and size devices. It will be up to the specifics of the device that you are considering. So I don't know which device.
But the thing is that they are very different from each other. And if you can use it on all of them,
Yes.
outcomes eyes and
Yes, the platform is vendor neutral. Maybe this is something that we should have stressed. That means that it doesn't matter if it's size, it doesn't matter if it's either the or other image modalities, and we can go into the details. You will have the same dashboard, same speed, zero wait. You won't have to wait a single second to load the image and get the results of the AI. And you have the same capabilities, and the AI algorithms are working in all images from all devices that are uploaded in the platform. So size, top-down, and high-level, the AI algorithms that you see are working for all three of them.
yeah, that's I imagine because it works very well, but I don't understand how can you put all the images in the system from other devices other than Heidelberg, since Heidelberg, for what I know, it's the only one who allows you to take the full volume in one shot.
So if I understand correctly, you mean that when you export the data?
Yeah, that's the problem.
Okay, so the thing is, we are not directly, you don't have to do the export manually. What Connect is doing is it's going to the database where the data is being stored. So you don't need to interact, that's the beautiful thing, you won't waste your time on that.
And it works like that in all the devices.
Yes.
Thank you for your excellent presentation. I'm Luis Arias, I'm working here at Barcelona.
Sorry.
I'd like to ask you, are you currently using this technology in other conditions such as diabetic macular edema, retinal vein occlusion, and specifically in patients with high myopia? Is the system available? Because due to the posterior staphyloma, perhaps it's difficult to compare the progression of atrophy.
Maybe I'll take the microphone due to the recording. So thank you for your question. I saw that there are myopic specialists here, so I knew it would come. So actually I did use it for outside AMD for DME. I also have a cohort of patients with DME that and that is also functioning very well. So I have also AI results in research. And RVO, I did not use it as part of the clinical research project, but in clinic, assuming the fluid would be really also powerful. But honestly, on the difficult cases of myopic, like with tractions and elevations and maybe pores, I haven't tried myself, but maybe the person from RetinAI can testimony whether others did use it, because that would be, of course, another application that is very important, especially for like sometimes they have fluid, and so what would be, I mean, before they may answer about application in a high myopic eye, and I think again, if you get a nice image, sometimes it's hard in high myopia with staphyloma to actually already get one image. I would think that the system could actually measure the fluid once you have the good image, but that I will leave on them. How would you actually think using it for your research or in clinical practice for high myopia? What would you do with that volume? What would be your idea behind that?
You know, we have several problems. We have the atrophy, neurovascular membrane, the traction, and perhaps I guess that it could be an important, helpful assessment for this patient. I don't know. That's why I wanted to know the experience. For instance, in the case of neurovascular membrane, we know that the response to treatment is good, but they tend to develop more atrophy in the long term, and it could be a prognosis factor. And to explain it to patients, we have this membrane, we can treat it successfully now, but in the future you can develop atrophy and perhaps you'll lose visual acuity. And the same for the progression of retinoschisis, traction maculopathy, because we know that many of these patients remain stable over time, and many of them don't require surgery. I don't know, I'm just guessing, but I think that it could be a helpful tool for these patients as well in the future.
And biomarkers also, the easy before and after surgery,
So we haven't done anything in myopia specifically, but it is of interest to us. And I know we spoke earlier, so yeah, it's certainly of interest to us. And we have a full-fledged research team at RetinAI, where we're looking at different indications. Inherited retinal disease is important to us too. beyond the work that we've done in GA, vascular AMD, diabetic retinopathy, DME. So, but yeah, that would be another area of interest.
Thank you. I'm Joël Luzon from France. I'm working in Rouen and Créteil. First, in your clinical practice, do you use IX anymore, or don't you use only the RetinAI software? You're following AMD and diabetic patients, especially. I have other questions.
So far I'm implementing AI-assisted imaging analysis in this wet AMD dedicated clinic to try to speed up the process for the patient. So that's not overall for every patient in my practice. Diabetes, RVO, I'm not performing that for each patient, but I'm trying to find a way to decrease the patient burden on treatment with wet AMD and also on clinics by implementing AI for this specific pathology. So it's like just to answer, it's like I thought as a cautious step-by-step introduction of AI analysis in my practice as a pilot project around neovascular AMD, which to me made sense due to the volume that we have to deal with in that specific indication. So far, that is where I'm using it in implementing that to use it in clinic.
So you can, I'm working with the viewer in the injection room. So I have a treatment installation. I see on the viewer and speak with the patient as I see the images and then inject and.
So no waiting time you have. I mean, you're very efficient. Yeah. So it's.
So will I have to open IX first and then open RetinAI at second? So to research by name because I will not have all the information on both, or RetinAI will completely replace IX and we don't use IX anymore for this specification injection room.
Yeah, the situation is very specific. So you are in the OR, you have the IX coming up on your computer, and from here you look at and you say yes or no, or extend or shorten. That's how you have your practice. So far as we need to download the image still to the system, I think to me it would be so far a bit soon to hopefully ask you to download as you are injecting.
No, this can be downloaded by the technician.
Yeah.
It takes the image, it downloads, the patient goes in the waiting room.
Yeah, and then it could be implemented. But I think that will, again, that is to you, but I think it will really be eased once we have the Connect version, let's say. Yeah.
I mean, in ideal world,
yeah, what would be your ideal world?
Can you only use the software and not use IX anymore?
No. Use both. You can use both.
So you have to use both.
So this is, and what it allows you to do is if you have multiple devices, so maybe HiX or Heidelberg for research purposes, Zeiss TopCon for every day. So what RetinAI Discovery is allowing you to do is take images from all those different devices and centralize onto the platform. And so the information that you would have on the platform is obviously all those images related to that patient. So you can have 10 years of visits, all the acquisitions, fundus images, things like that, OCT images. You would have gender, birth date, treatment dates, all of that information. Something that we're looking to is connections with EMR systems, and eventually we'll have alerts too in terms of specifically when treatment was administered. So.
And for the same patient, will the IA be able to make the measurements once in the top one, and the second time on Heidelberg, and the third time on the Zeiss?
And compare.
I can answer this one. The answer is we can do it, but what you will get is different measures. Because even if they are measuring the same structural information, they are not exactly the same amount of fluid. or the same amount there are slight variations because of the components of the device and the distortion of the eye. So you will most likely not get exactly the same measures. And there is a lot of research in that area where they are trying to compare. My recommendation would be that if you start in one device, that you continue in one device, so the metrics and everything that is being computed automatically by the platform, you have this continuation.
When I get back the images, can I look at all the scan of the volume and check the images, or I have just the central one?
You have everything.
Okay.
You can scroll down.
Okay.
Yes.
And the other thing about HRF. So there are several types of HRF. It's not easy even for us to say what is what. So there is a definition in the system or of the HRF. There is a measure. How did you decide that they are HRF? And also because now we are implemented it in DME, but maybe HRF and DME are different from AMD, so how does it work now?
Yeah, the question goes back to what were the parameters that were used behind saying that these are hyperreflective foci, and you're right, that makes sense because even in clinic, we sometimes don't know whether they are, what are these hyperreflective foci first, and whether they really are hyperreflective foci. It's a difficult tool. So really, I think you can answer regarding the metrics that were put to actually identify them as hyperreflective foci in the system.
Yeah, no, I think that's probably better for our research team. I think specifically we don't classify the different hyperreflective foci, but we do the segmentation across the whole volume, so you can see localization, especially when it's on top of the drusen, for example, meaning probably a higher risk hyperreflective foci or that phenotype of an AMD patient. But it is something that, as we get into more and more research, is even classifying PEDs, classifying hyperreflective foci. But I think even right now, having the counts of how many hyperreflective foci is very useful for research purposes.
And I really like your question because we're talking about AI and how it can actually help us. And actually, yes, it can. But I think your question is getting back to what human can add also in interpretation. Because as you said, if you have a huge PED with hyperreflective foci on the top of the dome, that would probably mean inflammation, pigment migration. As if you look at diabetes, the same hyperreflective foci would mean maybe microglial activation and inflammation, but would mean heart exudates in the retina. So we are doctors, we are clinicians, we are dealing with our patient. It's not the fact that, I'm counting the hyperreflective foci, I don't know what they mean. It means something for us, and we still to keep the human eye on the images. And I think that's why it's important, and also in the flow that I showed, that it has to be revised, because it's not just counting or just looking at it should mean something. But again, and I think that is the first point. And second is how you can actually trust the AI system that you're using. Because that's the first thing. We didn't even discuss that because you showed this beautiful example of specificity, sensitivity, accuracy at the beginning. But as a clinician, we need, before implementing anything, we need to know what this system is actually looking at and how accurate it is in terms of measurement and metrics that it will get back to you. So I think that would be also, again in this question, an important message for this morning. We as clinicians, if we want to imply AI, we need to first be sure that the system that we're choosing, we do rely on. And that is getting to the company and ask exactly the question that you did this morning.
Is the AI able to help us in diagnosis? I mean, for the neurosclerosis subtype, 1, 2, 3, detect polyps, and specifically for retrospective studies, we'll get all the images and try to find the real diagnosis, initial diagnosis of subtypes. and maybe not make ICG or the percentage of reliability of polyps?
Maybe you can start and I'll comment if needed.
Yeah, so what we differentiate is subretinal fluid, intraretinal fluid, pigment epithelial detachment. So we don't go into type 1, type 2, type 3 neovascularization, just by characterizing the pathological fluid.
And I think that is an important question because it may matters because we are looking for why would a patient have a better answer, whether that is the subtype. So far, all the biomarkers that were used, looking at TRT plus corrected vision at baseline to predict the treatment interval and the treatment outcome prediction for regarding vision, has been a failure. So it must be an answer somewhere else, and I agree with you that it's probably going to be into biomarkers and AI. So I'm turning here to Carlos, but I mean, I think in theory, to me, as clinician, it should be possible because we know that mostly for like type 3, we'll have a lot of fluid in the retina, maybe PED, hyperreflective foci in the external retina. So that is a typical, we know by our eye what is a typical type 3. And we do know what is a typical type 1, having this fibrovascular or mixed PED and a bit of serous fluid. So there should be a way to implement the type of fluid that is usually found in a type 1, type 2, or type 3, and the system should be able to then go back to, I think this is a type 1. I think that should be possible.
Multimodal imaging.
With multimodal imaging, looking also at OCTA, and so I think this is theoretically, it seems to me that it should be possible, but as I understand, not yet. Is that correct? Would it be possible, Carlos?
Yeah, the short answer is yes, it's possible. But at the same time, you cannot just bring a technology and hope that people are just going to use for the sake of it, because you need to understand where it's coming from. The way we did it is we built the foundation, the biomarkers that are going to redefine how you are thinking about diseases. So we can use it as Lego building blocks, so you can reach your own conclusions. And when we are looking at different stages of vascularization and the definitions, you can actually do that in a different way. The platform, and we haven't showed it today, that it has a search engine where you can actually define specific search criteria, where you're saying, if after the second visit we have intraretinal fluid above certain amount of nanoliters, send me an alert. So you can define those stages of choroidal neovascularization or whatever you want to define that you deem important for your clinic as a key parameter that the system is going to tell you, you need to look at this patient now because it has changed. So rather than us just telling you, this is the classification, this is the diagnosis, you can just build that, the building blocks and the foundation, and you can go full granularity to see where is this coming from. It's all in the open. So you can just build that structure by yourself. So rather than, to put it simple, it can be done. We first need to walk before we run. Because if you just try to jump to the final conclusion that people will, the first reaction is rejection, especially when you have patients on the line. So that's the reason why we are taking our time. I think for the question is very pertinent, and we agree with you.
And I just wanted to add there, I think building in the automated tools to allow you to put those building blocks on. So it's not manually intensive, but it's automatically setting the search criteria and then looking at your entire imaging database exactly for those specific biomarker thresholds.
Hello, I'm Julian, I work for Synotech in France, distributing bioengineering. So I'm really interested in your solutions. Regarding the new Connect plugin that you are developing, is it just all or nothing? Can you monitor that plugin to say, okay, I have 20 patients today to see, and this morning, this one I wanted to go to RetinAI, this one no, this one yes, this one no, in a simple way, just a yes or no checkbox or something like this that would be implemented then, or is it just all or nothing?
I didn't go too much into the details of Connect, but the short answer is yes. Let's say that you have a scanning pattern, so I want to send to RetinAI all the cube scans of 49 slices, so all the high-level scans that I take. I want them to be sent, but not all the others. You can configure that. So it's user-defined, and it goes much deeper. You can also even combine it with alerts so you upload all the tubes, and then the ones that have intraretinal fluid or has changed from the last visit, you can also indicate that.
Well, if there are no other questions, I want to thank everybody for attending this morning. And if you're interested in this, obviously we're very excited to bring